Hello and welcome everyone. So today let's learn about hypertension disorder in pregnancy. This is one of the most common medical complication of pregnancy, and it does have a very high mortality and morbidity rate. So that is why early identification and effective management plays a very crucial role in this in the pregnancy outcome. Okay, so without further ado, let's start. Okay, so let's start by understanding what is preeclampsia. So, the definition is it is the multi-system disorder of unknown etiology characterized by hypertension, where the blood pressure is more than or equal to 140 by 90 mmHg with proteinuria. Okay, and when after 20 weeks of pregnancy or gestation. Okay. The incidence is the hospital practice varies from 5 to 15%, where primary gravida consists of 10% and multigravida of 5%. Okay, and the variation is because there is not a proper documentation, or it lacks a uniform diagnostic criteria. Okay. Okay, so now let's see the classification of hypertension disorder. So we have gestational hypertension, preeclampsia, eclampsia, and chronic hypertension. So what is gestational hypertension? Gestational hypertension is where the BP is more than or equal to 140 by 90 with before proteinuria, and it does not show any proteinuria. Okay. So that means there is only a rise in the BP but no proteinuria. So preeclampsia is a gestational hypertension which means there is a rise in the BP with proteinuria. Okay. So eclampsia is a preeclampsia complicated with grand mal seizure or coma. And what is chronic hypertension? It is a known hypertension before pregnancy or diagnosed before 20 weeks of gestation. Okay. Okay, so now let's see the risk factor for preeclampsia. The first one is the primary gravida. We also saw in incidents where the primary gravida incidents were 10%, and with multigravida it was 5%, right? So young or the elderly first time mother, they are at a high risk. Okay, and this is because they have been first exposure to the chronic chorionic villi. And number two, if the person has any family history of hypertension, they are also at the risk of preeclampsia or hypertension. Okay, hypertension disorder in pregnancy. Number two is the placental abnormalities, where there is a hyperplacentosis from excessive chorionic villi exposure, especially with the molar in molar pregnancy, twins pregnancy, and diabetic. Okay, uh, or also it can also be because of the placental ischemia. Okay, number three, the risk factors are if the mother is obese, okay, or has a vascular disease. If the BMI is more than 35, and she has an insulin resistance, or pre-existing vascular disease, and thrombophilias, and these all can increase the risks of preeclampsia significantly. So now clinical features or clinical manifestation of preeclampsia. The first is the mild symptoms, where you will see the ankle swelling, tightness of the ring finger, and there will be a swelling gradually extended to the face, abdomen, and vulva. Okay, so alarming symptoms are headache, disturbed sleep, diminished urine output, epigastric pain with vomiting, visual disturbance or blurring of a vision, or blindness and dyspnea. Okay, so understand that preeclampsia is a principally a syndrome of sign, where the symptoms appears when symptoms appears it is usually late in the disease progress. Okay. Okay, so now let's see what is severe preeclampsia and how is it different from preeclampsia. Okay, so the BP about the blood pressure, there is a persistent systolic of equal to or more than 160 and diastolic of more than or equal to 110, where the blood pressure in preeclampsia was more than 140 by 90, right? So the protein urea excretion in severe preeclampsia is more than 5 gram, whereas in 24 hours, whereas in preeclampsia it is 0.3 gram. Okay, so oliguria, the urine output is less than 400 ml. It is same with the preeclampsia as well. And there in severe preeclampsia, you'll see a neurological sign like cerebral and visual disturbance, which is blurring of a vision, and persistent severe epigastric pain. You will also in during lab test, you'll also see the platelet counts has reduced. Okay, it is less than 1 lakh. Okay, along with that you will also witness HELP syndrome and pulmonary edema. Okay, so now let's learn about eclampsia. We learned about pre-eclampsia, severe pre-eclampsia, and now eclampsia. So, what is eclampsia? It is derived, the word is derived from the Greek, and it is called as like a flash of lightning, and it occurs when pre-eclampsia is complicated by generalized tonic and clonic convulsion. Okay, and or coma. Sometimes it may occur abruptly without warning in 20% of cases. And when all does it eclampsia can occur, which is it can be during antepartum. 50% of the time it is during antepartum, and fits can occur before, which is fit can occur before the onset of labor, and 30% is during interpartum, which is during labor. Okay, and 20% is during postpartum, especially within 42 to 72 hours of delivery. So that is why we keep a mother, if a mother has undergone cesarean section, or whether she has undergone delivery, sorry, normal delivery, we keep a mother for at least for 48 hours, right? So all these needs to be observed and monitored well. So now let's learn about the pathophysiology of preeclampsia. So the first is the abnormal placental development happens. So there is an spiral, the spiral artery in the uterus fails to remodel correctly, which leads to reduce in blood flow to the placenta. Okay, so when there is a low blood flow in the placenta, what happens? There is a placenta ischemia or stress. So what happens here after that, the poor blood supply causes the placenta to become stressed, and this in turn releases the harmful factor in the mother's circulation. Okay, so what does this factors do? So these factors damage the lining of the mother's blood vessels, which is the endothelium. Okay, blood vessels throughout her body. So with this, what happens? There is a widespread of vasospasm. So this damaged endothelium leads to intense constriction of blood vessels, resulting into high blood pressure. Okay, so when this happens, so then there is an organ dysfunction and complication happens. Okay, so increased blood pressure and vessel leakiness affects the organ kidney. So that is why there is a low urine output. Liver, that is why you have epigastric pain. Brain, you have a convulsion and there is a bleeding in the brain. And lungs, there is an edema, so that is why you'll have a the mother will have a breathing difficulty, leading to severe symptoms. Okay, so the first, because of the abnormal placental development, what happens? There is a low blood supply to the placenta. So when there is a poor blood supply, what happens? There is there is a placenta becomes stressed, and then it starts releasing a harmful factors, which what happens, which because of this harmful factor, the lining of the mother's blood vessels, especially the endothelium, what happens? It damage the endothelium, and after that there is a Now, because of this, there is a vasospasm, which is there is an intense constriction of blood vessel resulting into high blood pressure, and because of that, after that, what happens? There is an organ dysfunction. The mother starts showing signs and symptoms of pre-eclampsia. Okay, so now let's briefly learn about HELP syndrome. What actually it is actually a very rare but a serious complication which affects 10 to 15% of the preeclampsia cases. And what is more tricky is that sometimes it may develop even without maternal hypertension. Okay, and that is why it requires an immediate intensive management. So what is HELP? HELP is H stands for hemolysis. EL stands for elevated liver enzymes, and then LP stands for low platelets count. Okay, so there is an destruction of RBC cells due to with abnormal peripheral blood smear and elevated LDH. Okay, you also have an elevated liver enzymes where AST and ALT is more than 70 international unit per liter, and bilirubin of more than 1.5 1.2. And after that you have a low platelet count which is less than 1 lakh. Okay, which this low platelet counts actually indicates severe coagulation. Okay, severe coagulation dysfunction. Okay, so now coming to the management of preeclampsia, it is the drug of choice is magnesium sulfate. Okay, so Mexsulf is the gold standard, and it is also Mexsulf is a anticonvulsive drug. Okay, so how do you give this drug? So first is the loading dose. Okay, the loading dose, total loading dose is 14 gram. So 4 gram you have to give it through IV, and 10 gram you have to give it through IM. Okay, so 4 gram when you give, you have to mix or dilute it with a 12 ml of NS or distilled water. So 4 gram Mexel should be mixed with 12 ml of NS or distilled water, and you should give it through IV over 3 to 5 minutes. Okay, it should be given very slowly. And IM you have to give it like 5 gram in each buttocks. Okay, right and left, 5 gram you have to give in each buttock, deep IM. Okay, after that there is a maintenance dose. So 5 gram of Mexel IM you have to give it every 4 hourly, and it should be given in alternate buttocks. Okay, and this will continue till 24 hours. Okay, if you have started in the morning at suppose 9 a.m, so that will continue till 9 a.m next day. Okay, so every 4 hourly you will be giving 5 gram um, 5 gram Mexsulf, and that is in a alternative buttocks maintenance dose. Okay, so when you give magnesium sulfate, you also have to monitor toxicity, which is first is the knee jerk. It should be present. Respiratory rate should not be less than 16, it should be more than 16, and urine output should be 30 ml per hour. Okay, and when you give 4 hourly maintenance dose, you have to first check all these. If all these are present, it is checked, then only you need to give the maintenance dose. Okay, and every 4 hourly when you give, you have to check this 3 toxicity sign. So as a nurse, what all monitoring you have to do when a client is on a Mexel therapy? So first is the checking for a vital signs, especially first pulse, BP, respiratory rate, oxygen saturation should be monitored every 10 to 30 minutes, lungs and lung sound every 2 hourly, temperature and lung sound every 2 hours. Okay, you also have to do a neurological assessment. First is the deep tender reflexes, which I discussed it in a previous slide. That was knee jerk reflexes. It should be present. Level of consciousness asks for headache or visual disturbance, or when, if she is having a blurring of vision, epigastric pain. Okay, so that has to be checked every 4 hourly. So you also have to check for a fluid balance, make sure that strict intake and output is being recorded. Okay, and there has to be IV crystalloid should not be less than or equal to 125 ml in 4 hourly. Okay, so that is why you need to monitor for any sign of fluid overload. So also check for toxicity, which we discussed in the previous slide. Loss of reflexes, respiratory depression, or urine output should not be less than 30, or it should be more than 30 per hour. Okay, so now lastly, let's learn about the nursing management for eclampsia client. So the first immediate priority will be you have to maintain airway, breathing, and circulation, ABC, and then position the patient in the left lateral position, and then oxygen administer oxygen of 8 to 10 liter per minute through oxygen mask, and then establish IV access using wide bore cannula, and then you have an insert Follis catheter with urometer, because you have to maintain, or you have to record the input and output chart. And then you have a continuous monitoring, then you have to do the continuous monitoring of the vital signs. So what all the safety measures that you have to keep in mind? First is rail cot to prevent injury, tongue blade between the teeth when the mother is if a mother is convulsing, you have to put a tongue blade or the mouth gag. Number three is the use of pulse oximeter to check for her saturation, and frequent oral suctioning if there is a secretion. Okay, thank you so much. If you like it, please do share with your friends, and do not forget to like and subscribe.